Avis. So, well, I see there's still a few getting settled in virtually. So let's give everyone a chance to get connected audio-wise. And well, it's great to see some familiar names and faces as everyone's getting settled in. Just good to see everyone, and we really appreciate you attending today's session. So I'm going to give everybody a chance to get connected to their audio. Looks like there's a few still waiting. It's like Miranda's still trying to get connected, and Ryan and a couple of others. So let's give them a chance. Let their systems get plugged in here. And we have a few others joining us here as we get ready to get started. So I'm going to make sure I've got that waiting room disabled so people can join. Oh, again, it's just great to see everybody. Thank you so much for joining us today for another installment of our Essential Substance Abuse Skills training ongoing webinar series. So good morning or good afternoon, depending on where this broadcast finds you. My name is Steve Steiny. I'm one of the managers, program managers in the addictions department here at the National American Indian Alaska Native ATTC. I'm broadcasting to you live from the University of Iowa campus here at the College of Public Health. Have a fantastic speaker and presenter today. Dr. Avis Garcia is with us, and she'll be going over a lot of really important information. Some of this, for those of you that are practicing and have been practicing for a while in the behavioral health field, some of this will be a good review. And for others of you that may be just new to the field or are interested in getting into the behavioral health field, this will be some really great information for you to start to build your foundation for. So this is an ongoing series that is really centered around the fundamental components of working particularly in the substance use disorder field, but it can be applied to other related peripheral fields as well. So we're really happy to have you all here. Today, we are going to be reviewing information regarding basic counseling skills. And as I said, we have Avis Garcia here that will be reviewing a lot of information. We're hoping to have a little time at the end to field questions. I also have on the line or on the call here with us today is my colleague Parker. He is going to be sort of assisting, monitoring chat box. And if you're having any audio troubles or having difficulty getting connected, reach out to myself or Parker, and we can see if we can troubleshoot that, okay? But again, it's great to see some familiar faces and names. If you'd like, turn your camera on and join us. Otherwise, we understand maybe you're having lunch or you don't want us to be watching you eating. That's fine. I get that. But really happy to have you all here. I've got a couple of introduction slides to go through, and then I'm going to turn the floor over to Avis, and we'll transition and get the presentation slides up during that time. So again, welcome all of you to the ESAS Basic Counseling Skills webinar today. Well, as most of you know by now, this event is brought to you by the National American Indian Alaska Native ATTC. We are located, as I mentioned, at the University of Iowa, and we are part of a much larger network made up of 10 regional centers, a National Hispanic and Latino Center, and our coordinating office located at the University of Missouri in Kansas City. Let's see, there we go. This project is funded and supported by SAMHSA. Keep in mind the content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or our center here. Following today's event, we will reach out to you via email. We will include links or PDF copy of the presentation slides today. We're also recording this event, And this will be available at our Native Center for Behavioral Health YouTube archive for later viewing. If you have a colleague or a friend who wasn't able to join us, they could watch this presentation at a later time at their convenience. We'll also be offering continuing education units. We will provide 1.5 CEUs for attending this event, and you can request CEUs in that post email follow-up. And lastly, we will ask that you participate in a short survey. The survey is not mandatory, but it's very important to our center, and it allows us to continue to provide events like this. And your feedback is very important to us. So we'd really love to hear back from you. And again, it's just a very short survey. It takes just a few minutes. You can skip any questions you would like, and I assure you that all your responses are confidential and cannot be linked to you in any way. If you have any questions about this survey, please reach out to myself or Parker here at our center, and we're happy to take those questions. I know we're gathered here virtually today, but I wanted to take the time to acknowledge the land, pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll and Mr. Sean Bear. Thank you. Well, without further ado, I want to formally introduce our speaker today. She is a colleague and a friend, Avis Garcia, and she is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation. She has many, many years of experience working in the behavioral health and addictions field and has worked with a variety of populations. So she brings to the table a number of areas of expertise and clinical experiences. We're really happy to have her as part of our consultant team and advisory team here at our center. I want to introduce to you Dr. Avis Garcia. Just as a reminder, everyone is muted, but please use the chat box feature if you want to make a comment or have a question, and we'll try and circle back to those at the end of the presentation today. So I'm going to turn the floor over, excuse me, to Avis. I'm going to pull this screen down and put the new set of slides up. But Avis, I'll turn the floor over to you for introductions.
Okay. Okay. Good morning or good afternoon, wherever you're tuning in at. I appreciate you taking the time out of your schedule to attend today's presentation. I am on my 2nd year of presenting these ESAS presentations to prepare people to sit for licensing and certification exams. I have 20 years in the field of mental health and substance abuse counseling. I have earned all of my degrees from the University of Wyoming. I completed my PhD studies at the University of Wyoming in 2017. And in 2019, I started doing some webinar presentations for the Native Center for Behavioral Health. And I am a licensed addictions therapist in Wyoming and a licensed professional counselor in Wyoming. I am recently now certified in Montana, and they have a different acronym for certification here in Montana. So in Montana, I am an LCPC, which is a licensed clinical professional counselor, and an LAC, a licensed addiction counselor. So I'm duly licensed in 2 states in mental health and substance abuse. As Steve said, I have a lot of varied experience, especially in substance abuse. I have worked in all levels of treatment, and that is primarily the main focus of my work. And as a Native American myself from the Wind River Reservation, I like to incorporate Indigenous viewpoints, and I like to let people know I am a Arapaho, so a lot of what I refer to comes from my own personal viewpoint. I currently am the clinical services director for the substance abuse treatment program for the Crow tribe in Crow Agency, Montana. And that is where I'm presenting from today. So we will go on ahead and get started. Like Steve said, if you have any questions, feel free to drop them in the chat box. And at the end, I'll try to get to the questions that you guys post in there. And we'll go on ahead and get started with today's presentation on basic counseling skills. Today's goals and objectives are to look at counselor development, the use of micro-counseling skills, look at some counseling theory, talk about self-disclosure and keeping clear boundaries, and also cultural and ethnic issues. A person's substance use is not the problem, but rather a symptom of an underlying issue or issues for which they have yet to find a meaningful solution. So most people that are struggling with substance use are oftentimes turning to substances as a way to self-medicate or a way to cope with whatever problem they are facing. A lot of people, it's, just not understanding how to manage daily life stress or major life stress issues. And I know, coming from a Native background, that sometimes substance use can be intergenerational and run through the family. And I'm speaking from personal experience again. I've seen it myself in my own home, and that's what brings me to the work that I do here. You can go to the next slide. Counselor development. Okay. We are looking at the process of thinking and reasoning. Global versus linear thinking. Global thinking is a process where the answer is stated within the argument, assumes to be true, what you're trying to be prove. The conclusion is a single assumption. There is a certain starting point. The thought processes tend to jump forward and side to side through the steps of the project in an effort to see the big picture and tackle those areas where they have the most interest. So an example here is A is B, therefore B is A. Linear thinking is a process of thought following known step-by-step process, wherein a response is a step that must be elicited before another step is taken. It has a starting point and an end point. This is often utilized in problem solving, such as A equals B and B equals C, rather than A equals C. A significant difference between circular and linear thinking is global thinking. The conclusion is contained in a single creative assumption, and linear thinking, the conclusion is derived from multiple assumptions. The learning process. We have different kinds of learning. Some of us are visual, some of us are auditory, and some of us are kinesthetic. Interestingly, I had an appointment at Indian Health Services yesterday, and that was the first time I was asked what kind of learner I am, like how's the best way I learn. So I thought that was kind of interesting that they asked me that question. Of course, I'm one that considers myself to be kinesthetic. Visual learners are those who learn through seeing things, look over the characteristics to see if they sound familiar. A visual learner is good at spelling, but forgets names. They need quiet study time, have to think a while before understanding lecture, is good at spelling, likes colors and fashion, dreams in color, understands, likes charts, and is good with sign language. Visual learners can benefit from drawing a map of events in history, or draw specific scientific processes, makes outlines of everything, copy what's on the board, ask the teacher for a diagram sentences, takes notes, makes lists, watches videos, color codes words, and research notes, outlines their reading, can use flashcards, using highlighters and circling words and underlining, and I do that a lot. I have different colored pens when I'm working on some projects just to mark those things for myself. And I'm trying to adjust my note page here. For some reason, sorry, I'm having trouble getting my cursor to move in this page here. Okay. Auditory learners are those who learn through hearing things. These traits sound if they sound familiar to you, you may be an auditory learner. If you are someone who likes to read to yourself out loud, I do that. Is not afraid to speak in class, likes oral reports, is good at explaining, remembers names, notices sound effects in movies, enjoys music, is good at grammar and foreign language, reads slowly, follows spoken directions well, can't keep quiet for long periods, enjoys acting and being on stage, is good in study groups. Auditory learners can benefit from using word association to remember facts and lines, recording lectures, watching videos, repeating facts with eyes closed, participating in group discussions, using audio tapes for language practice, taping notes after writing them. And kinesthetic learner characteristic is learners who experience through doing things. Looking over these traits may sound familiar. Can't sit still for long, is not great at spelling, does not have great handwriting, likes science lab, studies with loud music on, likes adventure books, movies, likes role playing, takes breaks when studying, builds models, is involved in martial arts, dance, is fidgety during lectures. Kinesthetic learners can benefit from studying in short blocks, taking lab classes, role playing, taking field trips, visiting museums, studying with others, using memory games, and flashcards. You can go to the next slide. How do you learn and process information? Are you a global or a linear thinker? How do you process information that's presented to you? Who in your life do you believe processes information at the other end of the scale from you? How do you adjust your communication when speaking with a person who processes differently than you? And visual or auditory or kinesthetic, how do you feel you learn best? And I think I told you guys I'm one of them that has to have all of those. Okay, here's our first question. What type of learning process do you most identify with? The visual, auditory, or kinesthetic, or don't identify with any of these more than the others? Okay, we'll go on to the next slide.
We don't have an official poll set up for this.
Okay.
Just wanted to, just food for thought for the audience.
Okay. Well, moving on to the integrated developmental model. This is a progressive theory of professional development as clinicians in working in the behavioral health field. The integrated developmental model, clinicians develop in a step-by-step approach. Clinicians are seen to move through 3 levels of development in a relatively orderly fashion relevant to professional activities. The model allows for brief regressions when clinicians are faced with new or ambiguous tasks. This makes sense to me in many years of training and assisting new clinicians entering the field. It's very important to provide a step-by-step orientation and clinical training, starting with many of the current assessment and evaluation processes used to determine the patient's social and diagnostic history. And I think of it as building a foundation of a house. If you need a solid foundation, if you expect the house to stand and function in the years to come. The integrated developmental model, people are continuously growing and growth is not linear, but sporadic. Growth can be affected by changes such as your caseload, the treatment setting, your supervisory relationship, and your population served. The integrated developmental model continued, looks at levels of counselor development. So there's a beginning, there's an intermediate, and there's an advanced. A lot of beginning counselors, I have a couple and we refer to them as counselors in training, and they're often voicing their anxiety and sometimes their level of comfort. And I like that they're able to look at themselves and be able to ask for help and guidance in developing themselves as counselors. Some overriding structures are self and other awareness. So just knowing yourself and how you work. I know from personal experience that many counselors think they have to think and act and behave a certain way. And so it often interferes with your ability to work with people as a counselor, and being able to just get comfortable with who you are and how you work just really helps counselors to be more comfortable and develop their own style of working with people. Looking at your motivation and autonomy. Integrated developmental model, there are 8 growth areas. This is intervention skills, competence, assessment techniques, interpersonal assessment, patient conceptualization, looking at individual differences, theoretical orientation, and treatment plans and goals, and professional ethics. So those are all important parts of becoming a counselor. On to the next slide. The levels of counselor development. Level 1 is the beginning, 2 is intermediate, and 3 is more advanced. So your advanced people are someone, I guess you want to say, who has years of experience, and intermediate might be somebody who's been in the field for a while. And of course, your beginning is just coming right out of your programs. Level 1 clinicians are full of trust and hope. Level 2 experience a confusion stage, are striving for independence, less imitative, sometimes have rigid attitudes and belief systems, ambivalence, and instability. Level 3, this is the calm after the storm. You're able to concentrate, demonstrates development, and learning is a lifelong process. Level 3, I would describe as the beginning of a clinician's true work experience. As the clinician develops beyond the stage of growth and understanding, their work will take on more and more meaning professionally, personally, and spiritually. Micro-counseling skills. These skills can be learned, but I would safely venture to say that those of you listening today are likely innately gifted with many of these skills already, or you would not be involved in the helping profession. Some people just have that natural ability to really listen to people and offer really good advice. And I often encounter people who they don't even know what I do for a living, but then they just tell me their whole life story, and I'll be like, wow, that was really interesting. Like, and they don't even know what I do, but for some reason they just wanted to tell me their whole life story. So I just wanted to share that. Alan Ivey is a distinguished professor from the University of Massachusetts. He's the author and co-author of more than 40 books and 200 articles and chapters translated into 18 languages. He is the originator of the micro skills approach. Micro counseling skills. Here's a couple of really good books that you might want to check out that will go more in depth into the intentional interviewing. Again, here's Alan Ivey. He's like the main author of these books, Facilitating Patient Development in a Multicultural Society and The Essentials of Interviewing Counseling in a Multicultural World. Micro-counseling is an analysis of counseling skills that looks very carefully and in great detail at the elements of a counseling relationship. Regardless of the aims and methods of a counseling relationship, understanding its micro elements helps clinicians improve their counseling effectiveness. So you want to establish a helping relationship with the patient that is characterized by warmth, respect, genuineness, concreteness, and empathy. Looking at knowledge, you want to look at the theories, research, and evidence-based literature, approaches to counseling that are person-centered and have demonstrated effectiveness with substance use disorders, the definition of warmth, respect, and genuineness, concreteness, and empathy, looks at the role of the counselor, and looking at transference and countertransference. The skills in micro-counseling that we're looking at is your active listening, including paraphrasing, reflecting, and summarizing. So that's letting the patient know that you're understanding and checking with them to make sure that they're being understood so that they agree with what, maybe tell them, well, this is what I heard you say. And am I right? Did I miss anything? So this conveys warmth, respect, and genuineness in a culturally appropriate manner. So, when you're sitting with that patient, you don't want to be fidgety and not paying attention. You really need to focus and let them know that you're there to listen to what they have to say. So it demonstrates empathic understanding and uses power and authority appropriately in support of the client's treatment goals. Your attitude is to have respect for the patient, recognition of the importance of cooperation and collaboration with the patient. A lot of patients that don't understand the counseling process will come in and think you're just going to tell them what to do, or you have all the answers to whatever issues they're struggling with. So it's really good to share your viewpoint of what the counseling process means to you so that they understand that you're there to support them and guide them and help them make decisions, because most of the time they do have the answers already. Go to the next slide. Attending and attending behavior. So when you're attending, the counselor's interest in the patient is demonstrated by your eye contact, body posture, and accurate verbal following. Attending behavior also encourages the patient to talk and active listening. And when I see this eye contact here, I like to point out that a lot of Native people are not real comfortable with counseling to begin with. And a lot of times they're not going to make direct eye contact with you. Sometimes it's a cultural belief. And just because they're not making contact doesn't mean they're not listening. You know, I've had kids stare out the window or not look at me, but their answers and the way they respond indicate that they are listening. So eye contact is generally just to show respect and attention. So we do need to be, of course, looking at our clients. You need to be careful with touching and make sure you have distance. You know, we still need to have our personal space and respect the client's space. And verbally, we want to be encouraging. We want to ask questions to make sure that we understand and restate, paraphrase, and summarize. Can go to the next slide. Using open and closed questions. Open questions can't be answered in a few words, so no yes or no answers. They have to go into a little bit more detail. It offers encouragement and the patient will speak more freely. Closed questions is focuses on the dialogue, tend to be yes or no, tends to turn the focus on the professional and away from the patient. So you have to be careful not to get caught up in the question and answer trap. Sometimes when you're doing an assessment, it is actually different from doing therapy. So when you're doing an assessment, of course, you're going to ask a lot of questions. So one way of asking an open-ended question might be to tell the patient, you know, well, I heard you say this. Can you tell me more about that? What does that look like? And open-ended questions are a good way to elicit discussion and more sharing. Closed questions also have their place. When do you think these would be most useful with patients? Again, I think when it comes to assessment, you know, getting the specific answers would be a good place to use those closed questions. The next slide is the patient observation skills. So we're not just looking at them, we're listening to them and paying attention to how they respond. Nonverbal behavior, reflective listening, is 85% of our communication. Verbal behavior pays attention to the key words, discrepancies in patient's communication. So you might want to be able to explore mixed messages, pay attention to contradictions, conflicts, and incongruities. This is important in your training as a counselor, and you have to be careful. When I first started counseling, and I see it in new counselors, even myself as a supervisor, of wanting to problem solve and fix things. So that's not our role. So you need to be mindful of that when you're working with patients. The task is not to problem solve, but to understand where the patient is. Encouraging, paraphrasing, and summarizing. So reflective listening is using all three of these. You want to, when you work with the patient, you want to recognize and discourage behaviors that are inconsistent with the progress toward treatment goals. So skills here would be monitoring the patient's behavior for consistency with established treatment outcomes, presenting inconsistencies between patients' behaviors and goals. So we got to work on keeping them focused and keeping them on track of reminding them that we have a treatment plan that has the goals. Reframing and redirecting negative behaviors, teaching conflict resolution and decision-making and problem-solving skills, recognizing and addressing underlying patient issues that may impede treatment progress, and engage the patients to discover and use personal strengths and resources to reach their own goals. So being able to point out a lot of things that you notice that they are doing very well also helps to build their self-esteem and participation. Reflecting feelings. The patient's feelings are either stated or implied as expressed by the counselor. Feelings of the patient can be nonverbal or verbal. Some of the information they may share, you might pick up, everything that you're sharing with me here. Sounds like you're really frustrated, or you're very upset, just whatever it is, your vibes you're picking up, and being able to check that with the patient. The next slide. Reflecting meaning. Finding the deeply held thoughts and feelings underlying life experience. Paraphrase is to thoughts as reflection is to feelings, and it breaks down complex behaviors into parts. This process also allows for you to confirm and affirm where the patient is in the recovery process. Next. Empathy. Understanding what the patient is experiencing and putting oneself in the patient's place. Functions of empathy builds a firmer relationship with the patient. It enables the counselor to better understand the patient's behavior. And there are often times we don't understand. So, we can only share our feeling of what that might be like. Common problems with conveying empathy could be language and cultural differences between the patient and the counselor. Empathy is a great bridge builder in the shared human condition. However, don't lose sight of your role and purpose as a therapist. And we have another poll question. Which of these micro-counseling skills is the most challenging for you? So this is for you to think back on how you're working with people. How are you doing with your attending behavior, your open and closed questions, your reflective listening, and your empathy? Okay, now we're going to move on to the counseling perspective theory. The psychoanalytic perspective consists largely of using methods to bring out the unconscious, working through the past, transference relationships, focus on childhood experiences. Training is required beyond the scope of most clinicians. An advanced degree in psychology or psychiatry is necessary. This is the psychoanalytic perspective of Sigmund Freud. Looks at the struggle between the life and death instincts at the heart of human nature, dynamics of the unconscious and its influence on behavior. The role of anxiety motivates us to do something. Personality structure is divided into its components of the id, ego, and superego, and development of personality at various life periods. So if any of you remember your introduction to psychology class, everybody gets to hear about Freud. The id and the superego are constantly in conflict with each other, and the ego tries to resolve the discord. If this conflict is not resolved, we tend to use defense mechanisms to reduce our anxieties. Psychoanalysis attempts to help patients resolve their inner conflicts. To the next slide. More on the psychoanalytic perspective. Erik Erikson broadened the developmental perspective beyond early childhood. This is establishing a balance between ourselves and our social world, the biosocial approach. Crisis is equivalent to a turning point. Ego is developing strength and ways to deal with life tasks, and personality stages. The psychoanalytic perspective, this is of Carl Jung, the psychological aspect of personality development during midlife, views humans positively, looks at individuation, the spiritual approach, which is the meaning of life, with constant development and growth moving toward a balanced and complete level of development. Go to the next slide. The overview of the psychoanalytic perspective. The limitations of this perspective is a lack of ego strength needed for change. There is a biological predisposition. Great responsibility is placed on parenting of the mothers and fathers. And the cost. Long-term therapy can be quite costly if you're in a place where you have to pay for it, with difficult measurements of outcome. Some contributions of this perspective are it provides a conceptual framework for looking at behavior, looks at past experiences may pertain to the current life, value and role of transference, overuse of ego defenses can keep patients from functioning effectively, and the role of early childhood development. Psychoanalytic theory has been criticized in the way that it overemphasizes the importance of sexuality and underemphasizes the role of social relationships. This theory is not scientific and can't be proved as it is circular. Psychoanalysis has been greatly contributory to psychology and that it encouraged many modern theorists to modify this for the better, but using its basic principles and eliminating major flaws. The Adlerian perspective of Alfred Adler, which is why it's called the Adlerian, goal is to help patients identify and change their mistaken beliefs about life and thus participate more fully in the social world. People need to understand and confront basic mistakes. Family is an important factor. Cooperative therapy between the clinician and the patient. His emphasis is on the importance of feelings of inferiority, also known as the inferiority complex. It's recognized as isolating an element that plays an important role in personality development. Alfred Adler considered human beings as an individual whole. Therefore, he called his psychology individual psychology. Alfred Adler was the first to emphasize the importance of the social element in readjustment process of the individual. And the limitations and contributions of this perspective. The limitations are is difficult to empirically validate. Somebody's got some background noise on.
I don't know if somebody's got an open mic, but just check to make sure you remain muted. Thank you.
Okay, some of the limitations of this Adlerian perspective is it's difficult to empirically validate the basic hypothesis. A detailed exploration of early childhood, early memories, and dynamics within the family, contributions, working out an action plan to make changes in life. People are social goal-seeking decision makers, subjectively understanding the unique world of an individual, and it is sensitive to cultural and gender issues. On to the next slide is the existential perspective of Viktor Frankl and Rollo May. This is a philosophical approach that influences the counselor-patient therapeutic process. We are not the victim of circumstances because to a large extent, we are what we choose to be. Their emphasis is on self-awareness in therapy, a process of searching for the value and meaning of life, has an individual worldview. People are faced with the anxiety of choosing to create an identity in a world that lacks meaning. More specifically, existential therapy encourages patients to evaluate their own beliefs and situation, acknowledges their limitation as well as the possibilities for their lives, find meaning and purpose in their lives, develop more effective ways of communicating. Existential therapy can be highly effective for those who are struggling to make healthy life choices and accept consequences of these choices. This may include individuals struggling with addiction, anxiety, depression, and a range of psychological and behavioral issues. As with most forms of therapy, existential therapy is most beneficial for an individual who is willing to engage in honest self-evaluation. Individuals who are reluctant to search for meaning or who would prefer to receive immediate relief from their symptoms of their problems may not be appropriate for existential therapy. On to the next slide. The existential perspective limitations. It lacks a systematic statement of the principles and practices of psychotherapy, lacks rigorous methods. The concepts are abstract. It's highly focused on philosophical assumption of self-determination. However, the contributions are the person is the central focus, the emphasis on the human quality of the therapeutic relationship, and the individual's freedom to redesign his or her life by choosing awareness. The Person-Centered Perspective by Carl Rogers. And I am working in an agency that is CARF accredited, and part of the CARF accreditation requires that the therapeutic approaches used are focused on the person-centered perspective. So this is an important one. Carl Rogers, it is also a branch of the existential. It looks at the capability of self-directed growth, potential for understanding self, resolving one's own problems without the therapist's direct intervention. The therapist's role is to be rather than to do something. And the focus is on the person. Each of us has within us by nature a potential that we can actualize, through which we can find meaning there, and there is an innate striving for self-actualization. Person-centered perspective limitations. The therapists tend to be supportive without being challenging. Limited techniques, attending and reflecting. The therapist training, more emphasis on the attitudes of the counselor. All individuals may not have within them a growth potential or ability to trust their own inner directions. Contributions are stated concepts as testable hypotheses and was submitted to research and non-directive counseling. Motivational interviewing. This is a big one in the substance abuse treatment work. It's a counseling approach that was developed in part by psychologists William Miller and Stephen Rolnick. It is directive, client-centered counseling style for eliciting behavior change to help clients resolve ambivalence. Compared with non-directive counseling, it's more focused and goal-directed and departs from the traditional Rogerian client-centered therapy through the use of direction, in which therapists attempt to influence to consider making changes rather than engaging in non-directive therapeutic exploration. The examination and resolution of ambivalence is a central purpose, and the counselor is intentionally directive in pursuing this goal. Motivational interviewing is most centrally defined not by technique, but by its spirit as a facilitative style of interpersonal relationship. Go on to the next slide. Motivational interviewing is a form of directive client-centered psychotherapy in which patients are encouraged to explore the discrepancies between what they hope to attain in their lives and how they currently live and behave. So using specific language and techniques to empower patients toward positive lifestyle changes. Motivational interviewing is considered an evidence-based practice for the treatment of substance abuse by SAMHSA, has been extensively applied in medical care as well as mental health and substance abuse treatment. Miller and Rolnick changed the terminology from rolling with resistance to dancing with discord in the 3rd edition of their book. I appreciate how this further enforces the notion that it's not our patients that are resistant, in denial, are difficult, but rather how we as providers may be misreading their readiness to change, trying to push change into them rather than elicit their own desire to change from within. Imparting information does not work effectively when a client isn't ready to hear it. In addition, I might think I know best how patients should go about making change. However, patients know more about how change will work in their own lives. Resistance and discord in the provider-patient relationship provides us with an opportunity to revisit our intervention and change course instead of arguing for patients to change their behaviors. It is far more effective to elicit their internal drive to change. The more we elicit their desire, ability, and reasons and needs to change, the more likely they are to make that change. So we can't force them. We need to let them want that for themselves. Limitations of motivational interviewing is it doesn't address the urgency of change, ineffective leaders, no methodology for resistant patients. The contributions are triggers change in high-risk lifestyle behaviors, increases the willingness to get help and fight through addiction, increases participation rates during any treatment program, and allows individuals to encouragement during treatment and to establish self-actualizing goals. Okay. The Gestalt perspective of Fritz Perls. This is an existential and phenomenological approach based on the premise that people must find their own way in life and accept personal responsibility if they hope to achieve maturity. Therapist does not aim to change their patients, but rather assist in experiencing all feelings, avoid interpretations, and focus on the patient's behavior and the patient's self-awareness. Fritz Perls, from 1893 to 1970, developed and popularized Gestalt therapy after his training as a psychoanalyst in Berlin, then Austria. He moved to South Africa, establishing a training institute for psychoanalysis before developing his unique theoretical approach. His work emphasized a phenomenological and subjective approach to therapy, noting that many of us are split off our experience of thoughts, sensations, and emotions that are uncomfortable. One goal of his work is to move people into owning their experiencing and developing a healthy Gestalt or whole. Limitations of this perspective is the de-emphasis of the cognitions, thinking, not for all patients, especially if there's an abuse history, dangerous as a result of the therapist's power to manipulate the patient through techniques. Contributions, the action approach pays attention to verbal and nonverbal cues, compassionate confrontation, a perspective on growth and enhancement, and the here and now approach. There are some videos of his technique on YouTube if you are interested in taking a look at that. You go on to the next. The control reality perspective of William Glasser. This rejects the medical model. Patients live in an external and internal world. The clinician function is a teacher, our model. Focuses on personal responsibility and gaining control. Looks at the total behavior patients have psychological needs for belonging, power, freedom, and fun. Glasser was a developer of reality therapy and choice theory. His ideas focus on personal choice, personal responsibility, and personal transformation. Might be considered controversial by mainstream psychiatrists who focus instead on classifying psychiatric syndromes, as illnesses and often prescribe psychotropic medications to treat mental disorders. Glasser is also notable for applying his theories to broader social issues such as education, management, and marriage. Glasser is notably deviated from the conventional psychiatrist by warning the general public about the potential detriments caused by the profession of psychiatry in a traditional form of because of its common goal to diagnose a patient with mental illness and prescribe medications. This is one that I tend to lean towards and that I like. We can go to the next slide. Again, of each of these, we are looking at the limitations and contributions. So the limitations of this control reality perspective is the de-emphasis on the counseling process, doesn't take into account the unconscious, vulnerable to the counselor who assumes the role of an expert in deciding for others. The contributions, however, is the short-term focus dealing with conscious behavior. There is a contract approach. Punishment and blaming is a basic reality, and psychosis can be related to unfulfilled needs. The behavior perspective is Arnold Lazarus. There's an interplay between individual and environment. Emphasis on specific goals at the onset of therapy is based on scientific method. Patients are expected to engage in scientific actions to deal with problems. Therapist uses summarization, reflection, clarification, and open-ended questioning. There's those basic micro-counseling skills. Therapy is a collaborative partnership, and there are three major areas of development. In 1958, he introduced the terms behavior therapy and behavior therapist. And the limitations and contributions of this perspective are changes behaviors, but does not change feelings, ignores the importance of relational factors, does not provide insight, treats symptoms rather than the causes, involves control and manipulation by the therapist. The contributions are cognitive factors and subjective reactions of people to the environment, and systematic behavioral techniques and ethical accountability. Okay, the next one is the cognitive behavior perspective. This is a big one in the substance abuse treatment world, because we're always looking at the thinking and the behavior of Albert Ellis, Aaron Beck, and Donald Meichenbaum, also known as rational emotive behavior therapy. Thinking, judging, deciding, and doing. Emotions stem mainly from beliefs, evaluations, interpretations, and reactions to life situations. Has active directed techniques. Challenge belief system, self-awareness. Looks at the therapeutic relation as a collaborative relationship between the patient and therapist, and teacher and role model. Psychology. Psychological distress is largely a function of disturbances in cognitive processes, focuses on changing cognitions to produce desired changes in affect and behavior, and the patient needs to assume an active role. Cognitive behavior therapy is one of the few forms of psychotherapy that has been scientifically tested and found to be effective in hundreds of clinical trials for many disorders. Cognitive therapy is usually focused on the present, is time limited, and oriented towards problem solving. Here, patients learn specific skills that they can use for the rest of their lives. These skills involve identifying distorted thinking, modifying beliefs, relating to others in different ways, and changing behaviors. Okay, limitations. Does not encourage patients to address unfinished business. Personal warmth is not essential effective therapy. Potential for transference, less concerned with unconscious factors and ego defenses, and confrontational therapy advantage and disadvantages. The contributions are self-responsibility in maintaining self-destructive ideas and attitudes, emphasis on putting newly acquired insights into action, teaches patients to carry on that should be their own therapy, and comprehensive and eclectic therapeutic practice. Next is the family system perspective. So when you're working in the substance abuse field, you also want to make time to address the family systems and where they come from. Some of these family theorists are Murray Bowen, Virginia Satir, Carl Whitaker, Salvador Minuchin, Jay Haley, Chloe Madanes, Tom Anderson, and Michael White. The cause of the problem is understood by viewing the role of the family. Unresolved emotional fusion to one's family, the emotionally detached therapist, teacher, model, and coach. Here and now interactions between family members using techniques such as family mapping, enactments, and reframing. The family system perspective limitations. Our patients may be lost in the system and language. Dyads, triads, functional, dysfunctional, stuck, enmeshed, and disengaged. More research is needed. Contributions, neither the individual nor the family are blamed for particular dysfunction. The family is empowered and understanding the individual within the system. Next is the integrative perspective. This is creating an integrative stance, and it is truly a challenge. It does not simply mean picking bits and pieces from theories in random and a fragmented manner. It's important to ask which theories provide a basis for understanding thoughts, feelings, and behavior. You must have an accurate, in-depth knowledge of each theory. You can't integrate what you don't know. Take skill and training to know when, where, and why to use a particular intervention as a long-term venture, and to look at your agency's leadership, your supervisor, and your colleagues for support and guidance. I just want to add a brief note on all of the theories covered. The reason why all of those are covered is when you sit for the exam, there's a good chance all of what we covered might have questions pertaining specifically to those theories. I know a lot of natives have their own way of working with patients and working with clients and integrating our culture into the work that we do. That's just to let you know that that's the reason those are covered. We have one more question. Which of the theories are you most drawn to? So of all that we covered, there's several: psychoanalytic, Adlerian, existential, person-centered, motivational, interviewing, Gestalt, choice, reality, behavior, cognitive behavioral therapy, and family systems. So it's finding your own way and what works for you. And I also, point out that all of these are all created by people that are not native. And so as you continue to do your work as a native, you'll develop your own way of working with people that works for you. The next is assessing the readiness to change. I might speed it up a little bit because we've got several more slides to cover. In general, why do you think people change? The stages of change were developed by psychologists Prochaska and Di Clemente in the 1980s in an effort to capture the change process in cigarette smokers in treatment, and has since been used to characterize changes in other addictive disorders, including alcoholism. Prochaska and Di Clemente's cycle of change. And in practice now, we also have to put what level of stage of change do we see our patient in our work where they are, and helping them to understand where they are in this stage as well. And sometimes they do go back and have to recycle through the program again. So the stages of change are the pre-contemplation, contemplation, the preparation, action, and maintenance. If they're successfully able to have maintenance, they'll go out of the cycle. But I like to say in the substance abuse field, there's probably a 50-50 chance that our patients are going to relapse. And that's okay. It's a part of the change process. I like to let clients know it happens. It's a part of the process. So they're not so hard on themselves, and they understand, like, okay, let's just get you back on your feet again. You can go to the next slide. Self-disclosure and keeping clear boundaries. Self-disclosure is sharing personal, emotional, and experiential information. Self-disclosure on part of the counselor requires careful consideration. You want to consider alternatives and always be aware of the patient's needs. The patient's needs always come first, and to not do any harm. You always want to ask yourself if what you're disclosing is for the benefit of the patient. And I just had one of my counselors just this week tell me that one of a group of clients in particular kind of put him on the spot in questioning their background. And of course we had to discuss what did you share with them, and reminding them that you have to be careful of what you share, and being mindful of the clients. For some reason, it was my impression that the clients were telling them that they thought the best counselors were people that are in recovery. And that's not definitely the case. I mean, it was just the clients sharing their perspective, and the counselor at the time was feeling a little bit uncomfortable. So it's being mindful that we have to have those professional boundaries. Self-disclosure can slow down or even stop the sharing process. Patients may lose confidence in the counselor, and the patient may move away from self-focus. So we need to stay focused on the patient. It's not about us. We are there to facilitate the treatment process. And it's not for us to, tell about ourselves, but to keep focused on the client. How often did informal discussion occur? There is a study of 736 motivational interviewing and motivational enhancement therapy sessions. So, and all of this informal discussion occurred in 42% of all the sessions. On average, discussions occurred once or twice. 68% of clinicians had informal discussions 3 or more times in at least one of their sessions. 20% of clinicians initiated informal discussions, and 75% are more in their sessions. So it's really paying attention to how you're working with people. And I always let my counselors that I work with, that this isn't coffee time or informal time, that we need to keep focused on the patient's treatment goals. So, here's some self-disclosure guidelines. You want to wait and consider, why am I telling? And again, is it therapeutic, and is it going to benefit the patient? You want to be brief. Research suggests that long, drawn-out stories are considered therapeutic by patients and helpful and damaging to the therapeutic relationship. So it's best to keep it brief and to the point. Using I statements, make it clear that you are giving your opinion based on your experience. It can be easy for patients to assume that you are referring to your clinical experience and expertise, which can be misguiding. Consider your patient's values. Making disclosures that you know are not aligned with your patient's values are considered to be potentially damaging to the therapeutic relationship, as it can cause the patient to feel alienated. Think about why your disclosure is something they can relate to by considering whether it fits within their value system. And consider the impact when disclosure. Will the disclosure cause the patient to feel burdened? For example, revealing to a patient that your family member recently passed away could make the patient feel as though they can't discuss with you their own relationship issues. So check your agency's policies as well, as they can act as an additional guideline for you regarding your self-disclosure. Pros of self-disclosure: builds rapport and trust, provides validation to help the patient feel normal, can reduce the power differential, helps the patient feel that they're not alone, provides a role model for appropriate social interaction. Self-disclosure cons on the next slide. Can compromise the professional relationship, can move the focus away from the client, creates role confusion. The patient might feel burdened and may hold back or censor their own information. The patient might feel the counselor is too involved, can pressure the patient into disclosing when they are not ready by creating expectations. Another poll question: how helpful do you think informal conversations are in therapeutic sessions? Very helpful, moderately helpful, or very helpful. Okay, go on to the next slide.
Again, these are just sort of informal poll questions just to provoke some thought. Thank you.
Yeah, I think self-disclosure takes some practice. It's not something you can just, put right out there when it comes to working with clients. So again, it's always to ask why and how is it going to help that client. Looking at the cultural and ethnic issues. Culture is a key element that enhances opportunity for change. And like I said, a lot of these slides that I covered today are covered because that what will be on the exam that you're going to take. So it's important to know those different theoretical approaches and interventions, because those will be in test questions. So I'm one of those that's really big on culture. My program has a cultural counselor because that's how important it is to me. Culture is everything that people have, think, and do as members of a community or society. Material objects, ideas, values, and attitudes, and behavioral patterns. Culture is a template that shapes our behavior and consciousness within the society, is dynamic, shared, and learned. And when we're looking through a Native perspective, there are clear differences between the Western ways of thinking compared to how Natives learn. Our culture is shaped by our history, religion, ethnicity, geography, and group membership, which can include other subcultures. The addressing model, what does it do? It does give us an understanding for the effect of diverse cultural influences of therapists, different worldviews, helps us recognize where we identify with a dominant group versus minority groups. Like I said, I have a varied work experience on and off the reservation. So I've worked with a variety of different cultures and have to be mindful of those differences within those groups when we work with them. So it also helps become more aware of how identification with a dominant group can limit our knowledge and experience of groups that we don't identify with. So we have to have an open mind when working with all the different people that come in for services. Why is this important? Knowledge of the patient's salient identities gives clues to how they see the world, what they value in their life, and why they behave the way they do in certain situations, and how other people treat them. I mean, we're all different. There is no cookie cutter approach. So oftentimes I like to say that we're learning from our clients that, they know themselves best. And here is the addressing model. It looks at age and generational, developmental disability. Is this a disability acquired later in life? Religion and spiritual orientation. E is for ethnic and racial identity. S is their socioeconomic status, the sexual orientation, indigenous heritage, national origin, and gender. This is a very good acronym that helps you to be focused on all of the cultural aspects of people that you're working with to kind of keep yourself in check. Looking at privilege versus oppression, we are all addressing areas of privilege and oppression. We tend to be more aware of areas of oppression. Privileged areas present a greater challenge for therapists, and we need to consciously work to increase our awareness about our areas of privilege. Increasing our awareness, investigate your own cultural heritage and pay attention to the influence of privilege on understanding cultural issues, and work with patients and educating ourselves about the diverse sources of information, and develop sustain diverse relationships. So learning from those groups, not about them, but learning directly from them. Like I said, I am in a different culture. I'm an Arapaho, but I'm in Crow country. So I'm learning about them every day that I'm there. And I have a cultural counselor who is like my personal consultant there, because I don't want to offend anybody or step on anybody's toes. I want to be respectful of their ways as I work here as a member of a different tribe. And go on to the next page. Dr. Dwayne Mackey, Waktaya Naji Award for Excellence in Native American Education. He is of the Dakota, and it looks like Prairie Lands ATTC Native American Initiative Regional Coordinator, who dedicated his work in providing education to enhance knowledge to better serve Native Americans. There are 574 federally recognized tribes and Alaska Native groups in the United States, with more than 250 languages. We have different cultures, traditions, identities. This is an old census number that said 5.2 million people identified as American Indian or Alaska Native alone, or in combination with another race. And I just had this discussion recently of how now that there's so many different intermarried tribes, that it's rare you encounter a full-blooded member of one tribe, because people are relocating and moving to different areas throughout their lifetime. So like me, for example, I'm Shoshone and Arapaho, and I have a daughter that's half Navajo. So I mean, it's all these different uh, tribes now that are intermarried. So that's important to be aware of that, because sometimes we're all trying to decide, how do I identify? And my one friend actually did her dissertation on people of mixed Native heritage, of how they identify themselves in their life. And she discovered that most people tend to identify with one. Here's an example within the Dakota, Lakota, and Nakota tribes of the Sioux Nation. There are the Santee bands, the Teton bands, and the Yankton bands. So several different, this is one of those groups that is very unique in how it branches out. To the next slide. If you look at our United States, at one time, this was all Indian country, and now you look at how small that is. And right now I'm up in the Montana area, and then here's where I'm from, is the Wyoming area. I see these dark shaded areas, those are reservation territories. And go to the next slide. When you're working with Native Americans, you want to be mindful of the different cultural values. Most are seeking balance within their environment. We are a part of a larger system. We all have much respect for our elders, and we are always thinking about the future generations. Most of us natives that go to college and get an education, we're doing it to help our people. We don't do this for ourselves. We really want to help people. And prayer is a big part of our traditions. My program in particular, every day, we start our day with prayer in our office, and we smudge. And that's just a daily routine for us. Intervention with natives, development intervention should consider specific history, looking at unresolved trauma and how that affects grief across generations. And this whole COVID situation has really, I think, affected our Native populations, as to what we've been accustomed to throughout our lifetime. So I really see it as a lot of unresolved grief, not just for people coming into treatment, but all our Native people in our Native communities, as how that all happened. And then looking at the past experiences of each tribe. I think I was just talking to someone early this morning of, there was, they were talking about time periods like back in the late 70s and early 80s, where there were still places that didn't allow natives to enter certain businesses, or if they rode on a bus, they had to sit in the back, or, they were still really segregated and discriminated against at that time. And I always like to point out that, we as natives, we all have our different foods, our different dances, our different music, our different ways of dress. So I have really been enjoying being in Crow country and learning all about the people and what the big importance is of the powwow culture. It is, to me, it's always been a form of celebration, and I'm learning from the Crow people that the powwow to them is really a lot about ceremony. So it's, like I said, I'm learning here all the time, but that's because I want to, be respectful of the group of people that I'm working with here. Some tips for clinicians is to be aware of the many ways of perceiving and understanding and approaching health, wellness, and healing. Being careful not to misinterpret, stereotype, or mishandle encounters. Again, why I have my own cultural counselor on board that, oftentimes, I consult him on certain things that I do in the community where I'm working now. And being aware that our ethnicity is used to stereotype diversity, and it can lead to distrust. Assess a degree of acculturation within the target group. I think that's a really good one because I have a cultural counselor on board, and I'm not always perfect. Sometimes I make mistakes and I have to learn. Not everyone that's native wants to learn about cultural stuff. I've had some of the clients where I'm at now say, I don't want to be in that group. And, I thought, well, I thought you would want to learn about your culture. And they're like, well, I don't want to be in there. So I've had to separate the cultural group out and make it an option for them to choose and not feel like they have to go to that group. So it's being mindful of, not everyone wants to do that. So when you look at that level of acculturation, people, some people choose just not to go that route. So you need to be culturally responsive and, look at your own biases and stereotypes. We're running short on time here, so we'll just take a quick moment for tips for becoming culturally responsive. There are a lot of great books, a lot of good handouts. SAMHSA has this neat little fold up little pocket guide that is really good for giving to people to cover, that gets right to the point, that I really like, and it's free if you go to the SAMHSA website. And we'll summarize this and wrap up with reminding you all, we looked at the counselor development, we looked at the micro counseling skills, we looked at several theories and theoretical orientations. We discussed self-disclosure and how important it is to keep those clear boundaries as a therapist when working with your clients, and also being mindful of the cultural and ethnic issues. And like I said, I'm here in Crow Country, but there's 8 different tribes, so I could have some Cheyenne in the room and some Chippewa Cree in the room. So we have different several different tribes here. So that's been really interesting for me to work with here too, because I'm so used to mostly the Shoshone and Arapaho people that I've been with for most of my life. And then there's a bunch of references that are attached at the end here. And if you have any questions or anything, I have 2 minutes.
We're going to make sure that if you would like a copy of this presentation, we'll make that available. And we've also recorded today's event, so you could share it or view it at a later time. But I want to thank Avis for going through a lot of important information. And I want to thank all of you that were able to stay with us for the entire broadcast today. It's a lot of information. Thank you so much, Avis, and the rest of you.
I have a question, Avis. Where did you say I could find that pamphlet from SAMHSA? Do you know the direct?
It should be on the SAMHSA website. Let me see if I can locate it. I went to a training here in Billings and they handed them out, and it's just a nice little pocket card. Let me see if I can find it here.
Serena, if you send me your address, I'm going
That's it.
I'm going to mail you a packet of these, and you can have them and distribute them.
That would be awesome. Okay, we'll put them.
I would love that. Yeah,
Thank
I will.
You so much, Steve.
Of course, Serena. I will. I'm going to post my email here in the chat, and anyone can reach out to me here at the center. And Avis, I also have the ability to connect with Avis, but we can put her email in there as well. Or Avis, if you want to post your email in the chat. Yeah, these are just cultural cards. They're the trick to them is to try and fold them back up into this little packet after you open them. It's like opening a map and then you can't get it back the way you had it. Like, I'm going to send you this whole packet. We have many of these. So.
Thank you so much. They appreciate
it. On the SAMHSA website, it's called the Culture Card. And I am going to go into the chat box and type the link here.
Great. And Serena and anyone else, please feel free to reach out to me here at the center, and I'm happy to respond. But Serena, if you can send me your mailing address, I'll drop these in the mail for you. Old
Thank
school
you so
mail.
much, Tim.
Yeah,
Old school, okay.
that's right. We'll put it right in the regular mail.
Thank you so much, Pilar. I appreciate it. Thank you for the trainings too. I appreciate
course.
Oh, you're
of
welcome.
course.
I appreciate you taking the time to be here today.
it.
Yes, thank you, everyone. Until next time, stay safe, stay healthy, and stay connected. And we'll see you again. We'll broadcast next month. I think we're going to be talking about family counseling for the May broadcast. So please join us again, and we'll have a continued discussion. Until then,
Steve, I have a question.
of course, yes.
Are you from the University of Iowa? Is that where all these trainings are coming from?
Well, we are a national center, so we're located, our center is located at the College of Public Health at the University of Iowa, but we are a national network, so.
Right, but are you part of the PTTC or the Southwest PTTC? Which one?
Yes, we are part of the HTC network, which
okay.
includes the PTTC and MHTTC. Unlike a regional center, we're a national center, so we broadcast and connect nationally throughout the regions.
So where is your contact information?
Yes, you can
Is that
visit
going to
us.
be at the email, like a follow-up email or something?
Yes, there will be, if you registered for this event, Abel, we'll reach out to you post-event. And we
Okay.
can add you to our mailing list if you'd like.
Yeah.
But you know what I can do too is
I put my email in the chat, Mabel Almonte.
I'm so glad you did that. And I'm gonna post just the link to our website here too, if you want to jump in there, and there's a lot of information that's there that would probably really be something you might be interested in.
Yeah, this was very, very informative.
Well, so glad that you were able to join us, Mabel, and I want to honor everyone's time and just want to thank again everyone for joining. I wish we had time for more discussion, but we covered a lot today. So until we cross paths again, I will say Tokcha and take care, everyone.